discussion. So without any further ado, Professor Bruera, I'll let you maybe upload your slides and begin your talk.
Thank you so much, Dr. Kylie, for this wonderful introduction that I wrote for you about 10 minutes ago. And I would like to thank everybody who's showing up today. And the challenge we have today is to discuss situations like the one in this patient who had carcinoma of the prostate, rapidly progressive, and had bone pain due to his metastasis, progressive cachexia with loss of fat and lean body mass, fatigue, depression and anxiety due to his condition. He was a strong biker who used to ride his Harley across the Rocky Mountains and fish for salmon. And he had changed in many ways. His body image was a problem. And all these things happen as a package in our cancer patients. And we learned over the years that when the patient is ill, the family around is physically ill, financially ill, psychologically ill. And we learned many years ago that there is a need to treat this type of personhood suffering. It's a fringe movement that started in the 60s in the UK. And basically what we continue to do is not that different, but we have evolved from very end in the history of the disease to a little bit earlier. Now, mainstream medicine, while this was born, had not even established most of the specialties. So critical medicine, emergency medicine, and multiple specialties, including oncology, are about 10 years younger than palliative care. But we were born out of wedlock. We were born out of academic medicine. We're not a product of Harvard or MD Anderson or Royal Marsden. We're a product of the fringe. And that is why clinical programs and academic programs had a harder time and continue to have a hard time. The expression of symptoms in the patient's ESAs today is not just due to the lung cancer or the targeted therapy. It might be due to many other issues that are contributing to that, and that influences the drugs, invasive diagnostic procedures, and the management of the patient. The goal is to address suffering in our patients, and suffering, by definition, is multidimensional. We learned over the years that we go from the urgent to the important. We have to remove the red and orange areas so that we can move on into these other ones, and these other ones can influence the way the patient expresses the red areas. By nature, palliative care is complex. The oncologist, internist, family physicians tried, but they did not succeed at relieving suffering, and that is why the patient is being referred. So it's important to keep in mind the concept of complexity. And there are domains within that complexity that we learned over the years. With the patient and family in the middle, you have all these other domains that might be addressed to reduce unnecessary suffering, and you have a team around. A patient has all these needs in the middle, the family is trying to cope around, and you see all the other disciplines. But if you look at the disciplines, none of them have a single color. They cover a number of patient needs at any given time, and they interact with each other, and that's what we can do in the acute care setting, both inpatient and outpatient, to support the multiple needs. So we wear several hats as part of our practice in this area. This is the team that we need to have. This is the first team we had when we moved out palliative care to the outpatient area. As you can see, this picture was taken a few months ago. And this is the evolution. In the 60s, when the movement started, very end of life, days to live, mostly hospices. In the 70s, Belmont moved for the first time palliative care into the inpatient acute care facilities. And then in the 90s, we were able to move it into the outpatient areas. And then Jen Temel showed that early was better than just outpatient advanced. And then finally, COVID brought us telemedicine. So we can say that there was a hospice initial movement, then palliative care, then supportive care. And what we need to remember then is it's the same team, but focusing a little bit earlier on the patient's distress. Now, cancer has changed. And while it was described as this rapid deterioration, that was what we might call the more classic history, patients now go through multiple different trajectories. And we have learned that we need to adapt to those changing trajectories that will continue to change for years. The ESAS allows us to assess the patient's distress in less than 1 minute, and we have randomized control trials that have demonstrated that palliative care, when implemented in the early stages of the disease, dramatically changes the nature of the experience of the patient and family. If this was a new drug, it would certainly be already patented, because the level of evidence is very, very strong. Do we need to demonstrate that PEM works in Dublin or Cork? And we would say, no, we don't. We use the evidence that exists. Do we need to demonstrate that palliative care interventions work in palliative in Dublin or Cork? No, that would be analysis paralysis. There is good evidence out there. Initially, Jen Temel looked at advanced non-small cell lung cancer, and patients were randomized to integrated palliative care versus routine oncology care. The assessments were about the same, related to quality of life, and that was about 15 years ago. And what happened is there was better quality of life, better outcome index, less depression, less aggressive care. And what was surprising was that the survival, rather than being shorter, was longer in those who received palliative care. That was very surprising. And we also knew that patients were a little bit more aware of the disease. Now, the next study was done by Camilla Zimmerman in Canada with a mix of different advanced cancers, again, randomized to palliative care versus routine oncology, same outcomes, measures, and significant improvement at 3 months and at 6 months in multiple outcomes in these patients. In Italy, this study by Marco Maltoni looked at integrated palliative care as a routine, but they did not use the interdisciplinary team. It's like a urologist working without all the team that the urologist needs to work. So Marco did his best using the physician model only. The outcome measures were about the same, and they found improvement, but not that dramatic in many of these outcomes in these patients. Then Jen Temel came up with another nice study in lung and GI, again, randomized to integrated versus routine. And you can see that there was an improvement that was quite significant at 24 weeks, but it was a little bit more remarkable, particularly at the beginning, in lung than GI. And the main reason for that was that GI patients had less problems than lung patients. And so if there's nothing to fix, there's not that much to be measured. And the lung patients had a more severe symptom and distress burden, and that's why their response was more significant. But at 24, they both were quite significant. Now, there was also an improved prognostic understanding, and that has been quite consistent, that patients referred have better understanding of their disease. There was an emergency room referral suggesting that if you refer the patient early as compared to when the patient is already admitted and the primary team decides to refer, measuring all these outcomes, there was a significant improvement in the patients who were referred directly from the emergency center when they were getting admitted, as compared to when they were referred after they had been admitted, and they were referred earlier when they were referred by the ER. In this study, we showed Dr. Al-Dawahiri looked at randomizing patients who were receiving stem cell to inpatient palliative care versus routine oncology, and finding very significant improvement in multi outcomes. These were inpatients, not outpatients, as I showed you before. Significant improvement in outcomes, and also in induction for acute myeloid leukemia, also in patients. Another cohort, significant improvement in multiple outcomes as compared to routine care. This Danish study randomized patients to palliative care with variable intensity. That's the main difference versus oncology care. And basically, a lot of the patients had only one encounter, some of them had no encounter, and look at what happens. The significance drops quite a bit, and there's almost no significance because you cannot dilute your dose of the intervention to the point that it's now becoming a little bit meaningless. And that's what happens when you try to do very significantly limited interventions. So the systematic reviews also showed quality of life, symptoms, mood, no big difference in survival after that first study, but certainly never a study that showed a reduction in survival. So what do we know? Interdisciplinary, you see a lot of green, a lot of significance. MD only, some green. APN-led, not much. RN-led, not much, and primary done by the oncologist, the internal family doctor, not much. So what seems to be more robust as an intervention is a good dose by an interdisciplinary team. And there are design trials, design challenges in these patients, but there might be because there is not much trouble to be fixed. What do we know so far? It reduces symptom burden, improves quality of life, improves or does not reduce survival. And I didn't show in the previous studies, but there's very good evidence that it saves a huge amount of money to the hospital and the healthcare system. It saves it by avoiding unnecessary MRIs, molecular profiling, ICU admissions, immunotherapy, etc. What does not work? Excessively simple and primary, no evidence. Single interventions, one-time shot doesn't work. Why do they feel better? Well, maybe there's improved symptoms and they're able to adhere to treatment. Maybe suffering kills. And we're beginning to have a lot of evidence that people who suffer physically and psychologically live less. And it might be that also it reduces potentially toxic therapies. And probably it's a combination of the three. Are we getting to the patients in time? We learned after 3,000 patients at MD Anderson that we were growing very well. We were growing much more than the rest of the hospital. But if we look at the advanced cancer to death, the oncologist knew very well the patient had advanced cancer, but the referral was only 42 of the 250 days of advanced cancer. And when we looked over the years, we found that we had no improvement in the amount of days in palliative care in addition to oncology. And there are the Kaplan-Meier's, they were kind of flat. We knew that solid tumors were referred a little bit earlier than liquid tumors because, as we know, our colleagues from hematological oncology have a trend to treat their patients until 3 or 4 days after death. And so we knew that that was going to take a little bit longer. And we decided to make this survey, anonymous survey of physicians and advanced practice providers to understand their attitudes, what happened. And what we understood is that they were quite willing to refer a patient early if the patient was not receiving treatment anymore, very much, but they were not as prepared to refer a patient at earlier stages of their disease when the service was named palliative care as compared to named supportive care. And that difference was quite significant. And then we tried to understand why. And it was because they perceived the name palliative as reducing hope on the patient and family as compared to the name supportive care. Just the name. We didn't say anything else. Would you refer to a service name this or that? And they were quite happy with the care overall. They were quite happy, both oncologists and mid-level providers. And so we repeated this a decade later to see if things had changed. And we found the same thing. Both hematological and solid tumor specialists anonymously were much more likely to refer patients who had, a name, the service was named supportive care as compared to the name palliative care, especially at earlier stages. And once again, they felt the name was a barrier for palliative and not for supportive, and that it could decrease hope for palliative and not so much for supportive. So they were worried about this business of the patient or the family Googling palliative and getting hospice, end of life, death, etc. So at Anderson, we did three things. The goals of CAR, integrated education and change the name of outpatient center and mobile team to supportive care. Goals of CAR means basically when you buy a car, you want to drive it. You want to go to the beach, you want to go places, and there's two attitudes. One of them is be unrealistic. Nothing is going to happen. Do not wear a seatbelt. Do not buy insurance. Do not lock your car. And that doesn't sound very reasonable. Or you can have exactly the same goals, but take precautions. With your cancer, it doesn't make any sense that you're told, be unrealistic, look for the cure, look for living indefinitely, and not take precautions about who's going to take care of me, what are my funeral arrangements, who's going to move in with me, all those things that I might do just in case things don't work out. And we used that not only with patients and families, but with our referring oncologists to help them understand that we could help be the plan B for all these patients. So integrated, never sequential. And we moved from this model in which one person was trying to do everything, this model in which one person was referring to a whole bunch of services and creating extra work, but also potential conflict for those colleagues, and also for the family who had all kinds of messages, to a model of integration with palliative and supportive, and then using in a more discrete way the other disciplines. Change the name to supportive care. We immediately saw two things. An increase in the length between referral and death, but also a massive increase in the number of referrals, 41% in 6 months. And here you see the Kaplan-Meier's starting to differentiate quite significantly after the name change. And this is what has happened progressively. Over the years, Anderson has grown about 400, since 2010, the demo study until now. Anderson grew up about 400%. We grew about 2,200%, about 5 times more than the institution. None of that promoted by the executives, 100% promoted by referrals from our colleagues from oncology, radiation therapy, etc. And of course, that required us to understand that this increase is increase in burden, these encounters. And so both inpatient and outpatients, and this required us to see this line here that is increasing the number of positions so that the bars that you see there, the number of encounters per year for the faculty, became manageable. Otherwise, it would immediately burn out the team. Now, we also had to plan because patients started being seen more frequently in the outpatient area. We had to have templates for them. And for the first time, we noticed that patients were telling us that their referral was just in time. 3 years before, that study resulted in 80% of the patients telling us that their referral had been too late. But by that time, we noticed that 72% felt it was right in time. Actually, we had a few percentage that said it was too early they had been referred. Now, we need different structures, and those are always frustrating to administrators. So the outpatient center, we don't want to have a waiting room, but we're told you need to have a waiting room, and we don't want to have somebody who's mutilated, cachectic, depressed, sitting in front of somebody else waiting for an appointment. So we keep an eye and bring them in immediately, and we visit them inside a room. So they are having the combination of privacy and comfort they need. We put the sign on the actual ceiling and the art there too. That is what patients on stretchers and wheelchairs need. These are clinicians. The ones who welcome the patients are clinicians. They need to understand distress, anger, the things that happens close to the end of life in our patients. We need the team. We need this tool that we call fluoroscopy, because Anderson is so obsessed with square footage and use that we call it fluoroscopy, because fluoroscopy makes money and sitting and talking doesn't. So we call it the fluoroscopy room for complex conversations that are medical interventions, complex medical interventions. We try to have a bed and chairs to sit, and we need to have structures like administrative autonomy, physical space, electronic platforms, faculty and staff positions. We need to have processes that can only happen when we have those structures. That is universal patient assessment, seamless movement, rapid referral process, unified approach, and burnout monitoring. And finally, we can expect now outcomes. That is alleviation of unnecessary suffering, better end-of-life metrics, a lot of money savings, and burnout prevention. How can we increase the expectation of improvement? How can we have a placebo on the suffering of a patient? All these things can help, but all these things needed us to do the studies to try to convince our executives that those things might be important for the patient suffering. And so we needed to have a nurse assessment, and that is important because the nurse can do all these things to the patient, can do the ESAs, can assess multiple other aspects like delirium, can assess risk when the patient is going to get opioids, can have a comprehensive history, and then discuss with us. And we can also respond to the patient's phone calls or actively phone the patients from our center to their home to see how they're doing. We can have counselors right on site, right there, and 52% of the patients are seen at least once by them. And we can have them seen virtually or in person. And we also have learned that patients can need to walk up in person or electronically, because those who walk in are significantly worse in terms of symptom distress as compared to those who are scheduled. So always allowing walk-in saves a lot of time for the patient and family, distress, and emergency room use. So this patient had essentially right upper lobe, non-small cell, progressive, and the patient developed anorexia, fatigue, mild hypoepic delirium, coma, death. In a sense, an easy end of life, an easy death. This other patient had exactly the same histology and molecular profile, only 3 centimeters higher, and now she was in excruciating pain and multiple hemoptyses, opioid neurotoxicity. So end of life biologically can be the same, but from the personhood perspective can be dramatically different. And that's where the palliative care unit plays a huge role, dealing with the most difficult problems and addressing also education and research. It's not new. The first PCU was established in 1976. So this is an intensive care unit for personhood suffering, trying to humanize the place, get the team, get the fluoroscopy room, and occasionally getting the person to have this type of marriage outcomes, bringing the family, making sure that the family is always welcome, including those family members that I personally don't like at all, but there they are their family. And in this case, mom and dad wanted to have their daughter get married. We convinced our nephrologist to dialyze dad with multiple myeloma and renal failure. We put him on opioids and methylphenidate. And there's the groom, there's the bride, and there's a chaplain desperately trying to show up in the photograph. But this is important. These are outcomes that are meaningful. And that reduces unnecessary suffering. Now, COVID started all of a sudden at MD Anderson, and basically what happened is MD Anderson closed everything, a lot of outpatient services, and we had the advantage of hurricanes, and because we had an outpatient center, because we had templates, we were able to contact the patients during hurricanes and have them go into their cabinet box and say, okay, let's look at what you have, let's look at what you can take until we can see you again, and drugstores open. So we were able to make that transition, and we made it very fast from before virtual to virtual. Of course, we violated confidentiality. That was an emergency, but we were able to demonstrate that all these assessments could be easily done virtually for the patients and families, and done over 1 week transition. And there you can see that there was a big transition quite fast. So we learned that allows people to access. We also decreased no-shows because the patients were at home, and we decreased walk-ins, and that was bad. It needs to stay, and you do need national licenses so people can practice anywhere and access patients everywhere, including opioids. The metrics improve very dramatically when you are delivering outpatient as compared to inpatient palliative care. All these metrics are so much better when the patient is referred in the outpatient setting. Now, there's 3 ways. One of them is the oncologist sends me the patient. The other one is the company, the hospital, the healthcare system automatically refers the patient when there are some things that are present. And the third is some of these automatic criteria can be sent to the oncologist. I personally have never supported number two, and we have the highest access in the United States. And the reason for that is this is a very powerful relationship between the oncologist and their patient. And you don't want to in any way be imposed on them. You want to be consulted, invited. So this is the way we have grown. And we believe that occasionally providing this information in the electronic health record, hey, look, you might want to call Dr. Bruera because there are some things in your patient that we want you to know, that might be okay. But enforcing the automatic referral is not necessary. And I believe there are some ethics there because that oncologist, who's the primary doctor, did not invite me. So early integration changes outcomes, can happen in outpatient, needs to happen in the outpatient center. Each institution develops the threshold, and small is much better than large. So until they give you the size you need, see a number of patients and go home. Because the moment you dilute your intervention by seeing a large number of patients in a very limited amount of time, you're not going to get the outcomes that you want to get. That is the reduction of unnecessary suffering. So that was what I thought I would bring to you today. And of course, I would be delighted to answer any questions or any comments you might have about what I presented or anything else that comes to mind. Thank you very much.
Eduardo, thank you. Thank you so much. Like so much of what you've said there in the latter part really resonates, I think, with what we're experiencing in specialist palliative care in Ireland here, particularly in our hospital system. Like, for example, today I am the sole doctor for the entire major tertiary referral centre in the region, with just 2 clinical nurse specialists, with no dedicated social work, no psychologist. You know, we don't have that multidisciplinary team in our acute hospitals, and we are at that crossroads where you're trying to decide: do we see everyone thinly, or do we see the few that we need to see deeply and do the work that we're trained to do and make the case for padding out the interdisciplinary team? So kind of your lifelong expertise around the direction of travel there is actually quite helpful from what I'm hearing. It's go after what you do well, which needs to be interdisciplinary and adequately resourced. Is that kind of your experience, Eduardo?
Well, 100%, 100%. You know, surgeons have been doing that for many years. If you do a cholecystectomy and it takes you 5 hours, it's malpractice because it should be done much earlier. But if you do a pancreatectomy in 20 minutes, it's also malpractice. You probably left half of the pancreas there, or the patient's going to have a complication. So there is a minimal amount of time. This is complex care. This is not just, you know, change the laxative and send you out. And what we learned is that it is the oncologists who are sending us the patients because they perceive that the burden is alleviated so much on them. But that only happens if we're able to put the time to see these patients. Now, what I find ridiculous is that our bosses don't understand that Dr. Kylie saves millions. And she doesn't save millions because of the billings she makes. She saves millions because she avoids unnecessary utilization by patients who really don't need that type of utilization. And so, but this is also demonstrated by many times our executives and our administrators don't read the literature, and they're unaware that we are a money saver. We're not a money maker, we're a money saver of unnecessary expenses. At a time when we don't know how to pay for expenses, well, the money, instead of going into AstraZeneca, Bristol Myers, or Siemens, the money will go into paying Irish people to help Irish people to live better. So it's a matter of reallocating those resources. From my own perspective, I believe it's so important to help our people because, believe it or not, with my name and my looks, more than 50% of my DNA is Irish through my mom. And basically, I had multiple epigenetic influences over the generations, including my own upbringing. And I am deeply grateful for that. And I believe that it is part of the Irish character to help those who are vulnerable and suffering. And this is exactly an Irish character that I believe is so important that you be proud of, having taken care of these vulnerable people. I started visiting Ireland in the 80s when of course the country was in a much more different situation than now. Now you do have the resources. Ah, my goodness, this is such a wonderful opportunity.
Okay, thank you. I'd encourage anyone else with some questions to enter them into the chat. Miriam Colleran, I can see you there thanking Eduardo for a magnificent presentation and that outcomes are meaningful and cause reduction in unnecessary suffering. We have Dennis O'Mahony, excellent lecture. Professor Bruera, I presume the same principles and practice organisation apply to non-cancer patients as well as cancer patients. Is that the case?
Absolutely. And there's the beginning of a body of evidence about CHF, about COPD, and about dementia. And I think that what we can say is that the outcomes seem to be similar. The levels of distress are very high in those conditions also, but also the ability to reduce unnecessary distress and save money are quite significant. So there is an opportunity. There is an opportunity to really make huge changes in the distress of the patients and families, save money, and also make the biomedical practice much more enjoyable for those who are focused on the biomedical, because we are focused on the person. We're not focused on the disease. And therefore, it's such a wonderful integration. And yes, for non-cancer, I think that's absolutely possible.
I don't want to hog the floor, but could I ask, just, I find across health systems and even within our own internal systems, palliative care, Eduardo, is being expressed through different linguistic identities. You've touched on it there: palliative care, best supportive care, symptom control, hospice, each carrying different meanings in different places in different countries. Like, from your perspective, does this variation in language materially change what patients experience, how services are organised and funded, and importantly, how policy is written? And if so, like, as palliative care leaders now, should we be intentionally shaping the language and the identity of our specialty for the future? Do you think that is important?
I think that's a wonderful point, Fiona, and I think that's you know, I cannot, as you can imagine, I am not the best to talk about words, because you live in the country that pretty well has the best writers in the world, and therefore you probably can find out as a nation what are the names that work the best. I can say that globalization has changed things, because now people Google, people go into more global names, and we have repeated our research in other areas showing that there is a problem with palliative care being associated with end of life and death. And therefore, making that clinician, that oncologist, that APP, delay another month, another week, another 3 days, the referral, and that generating volatility, generating complications and problems that could have been addressed. And therefore, yes, choosing the right language, but also having in mind the patients, having in mind what they, in that situation, and their relatives, what are they going to be looking for in social media, in Google, that can be the right name to accompany them. Accompaniment, support, symptoms. I mean, I don't know that I am the most qualified person to choose one name. I do know that we carry a burden in palliative care. Now, our palliative care unit at MD Anderson is called the palliative care unit, because this is a late situation of transition to the end of life, and we don't want to hide that in any way. What we want to say is that in the outpatient setting, when patients are starting their trajectory towards advanced disease, there's a lot to be offered, and it seems to be like the name palliative doesn't help us very much.
Yeah, and you've done some interesting work on chatbots, haven't you, and how they differ and how consistent or inconsistent they are in their terminology. So we probably need to be influencing kind of what's out there on the internet as well, so that accurately reflects. I see Tony O'Brien, Professor Tony O'Brien, has a question here as well. Hi, Eduardo. Thank you for a wonderful presentation, always inspiring. Do you have insights into the challenges of delivering care in the ICU setting?
Yes, thank you so much, Tony. Thank you for being here, and thank you for all you've done for for your country and of course for Cork, where it happens to be that my family comes from. So I'm grateful to you after several generations. And ICU and emergency center are a hard hat area because you have three teams. We have the primary team of that patient, you have our supportive and palliative care team, and you have the local team, the emergency team or the ICU team. And so that triad makes it complex in the decision making and communication. And I think that one of the challenges in that setting is that many times the patient and the family are quite confused about prognosis, about what comes next, about what can be done. So we believe that it's so important to do two things in the ICU setting. First, to talk to both. Talk to the ICU team and also talk to the oncologist, cardiologist, whoever was managing that patient before, to make sure that the family and patient get a similar message. And second, to as much as possible work on what can be done the first day, that is the unnecessary pain, unnecessary delirium, unnecessary dyspnea, constipation, whatever we're going to do, and then move on into the end of life. What we find very distressing is when you get called with somebody who is already having a systolic of 80 and is not making urine and is at the very end of life, and they want you to have a goals of care conversation. In our case, when the person is referred for the first time in the ICU close to end of life, we consider that a sentinel event. Why did this patient not get referred a week ago, 10 days ago, a month ago, 4 months ago? How do we avoid this from happening again? We don't want this to not happen, because I think that our presence there is better than no presence, but it's clearly such a late referral that it puts everybody in a very difficult situation.
Eduardo, I feel like we're squeezing you for all of your information. Would you manage one more question? And I know it's from the group downstairs here in the hospice in Marymount, thanking you, as everyone is, for a wonderful talk. And just wondering, as you were speaking about the rapid expansion in MD Anderson palliative care, supportive care, how did you go about priming the service and the resources? Like, is there, what would be your top 3 tips for us here trying to prime our service for expansion? Because that's what needs to happen here.
Absolutely. And there was a time when everybody was saying, oh, palliative care is wonderful, sending you the patients, but not putting the resources. So you need to find, what does the oncologist have? What does the gastroenterologist have? What does the internist have? And I tried to look for that. And I went to my boss and said, hey, listen, I see my people here at 7 o'clock in the morning and leaving at 6 o'clock in the afternoon. This is not sustainable. We're all going to get burned out. And my boss said, hey, Eduardo, everybody arrives at 6:30 and everybody leaves at 7 p.m. So what you're telling means nothing. So what did I do? I didn't know what to do. But in Texas, if you have a pulse, you have a car. Nobody uses, bicycles or public transportation. Everyone gets by car. So we looked at the parking records. And I had my 2 research nurses and I reviewing parking records. And it took months, and they were saying, Dr. Bruera, we didn't come here to look at parking records. We wanted to do research on palliative care and so on. I said, just be patient. Let's look at that. So it took us 2 or 3 months to clean the data. And then I went back to my boss and I said, hey, listen, there's a metaphysical phenomenon occurring here. Your doctors arrive at 6:30, but their cars come around 8:30. And then your doctors leave at 7 o'clock at night, but their cars have left at 5. And look at my case. In my case, that doesn't happen. And so I happen to have a wonderful, honest big boss at Anderson. And he said, okay, shut up, Eduardo. How many positions do you need? Because sometimes it's a matter of coming up with those outcomes that are going to have to be, in this case, Cork specific, that will allow you to really determine what is the number. You don't want more than what others have. You want the same. You want to have the same amount of encounters and positions that allow you to do your job well. And then what is the outcome that is going to be able to allow you to compare and to bring up and say, you know what, we're not achieving our clinical goals because we don't have the resources. And we're also not achieving our academic goals. And look at what happens. Opinions are not good. My opinion when I went to see the boss didn't go anywhere because he had a bigger microphone, and in absence of data, all opinions are good, but the boss's opinion is more important. But data can change things.
Excellent. So before we leave this meeting, we want the car registration of every single oncologist on this call to be entered into the chat until we conduct a similar study here in Cork. Eduardo, I think it's a compassionate meeting that allows everyone to go away maybe 5 or 10 minutes early and digest the wealth of the information that you've shared with us. We can't thank you enough for your time, and we would love to invite you back at another point to talk more to us about your experiences. But for today, we'll close this meeting down now. Thanks everyone for your attendance, and back to busy days, hopefully more informed and inspired. Thank you all.
Thank you. Thank you so much, Fiona. Thank you everybody for showing up. And you know, I as much as I can, I will never say no to Ireland because my mammy has her wooden spoon. She's watching me, and my St. Patrick's is always with me, as you can see him hopefully here. And I will always be there. So if you need anything, contact me at any time. Thank you.
Eduardo, you're an honorary Corkonian at this point. We will talk again.
Thank you.
Bye-bye.
Bye.